Well, thank you very much. It's really a pleasure to be part of this combined SCCT ASPC webinar, part of a series entitled Why Atherosclerosis is All That Matters. And today I'm going to be talking about the use of quantification of plaque with CTA to motivate and inform medication, diet, activity, and education for prevention of cardiovascular disease. Here are my disclosures. So I'm going to frame our conversation really within the context of 4 questions, starting with what are the changing paradigms in ASCVD risk assessment? 2, how does the presence and quantity of atherosclerosis depicted on CTA influence risk and therapeutic decisions? Does direct visualization of the disease itself, that is atherosclerosis, facilitate greater adherence to therapeutic lifestyle changes in medical therapy? And finally, how can we integrate CTA plaque imaging with treatment and surveillance recommendations? So starting with the first question, which I'll rephrase as, why are we actually even talking about CTA-based plaque quantification when we already have established cardiovascular imaging paradigms? For decades, we've been using stress testing as a tool to triage patients for cath and revascularization. But let's look at some trends that have been observed in the last decades. So on the top left, you'll notice that there's been some secular changes in the proportion of SPECTs that are abnormal or demonstrate ischemia. So in the early 90s, it was quite common to have abnormal SPECTs, pretty common also to have inducible ischemia noted on SPECT exams in the range of 40%. But now in the modern era, you can see that it's quite uncommon to see abnormal SPECTs, and ischemia is only noted on about 5% of myocardial perfusion scans. As a consequence, most cardiovascular events, most MIs, occur in individuals with a normal functional study. One is because, obviously, most functional studies are normal. And 2, we've known for a very long time that patients with non-obstructive coronary disease go on to have cardiovascular events. They go on to have MIs. And in fact, that is the majority of events. And this is because the disease that we're interested in isn't really ischemia or stenosis. The disease is atherosclerosis. And we know that plaque burden predicts risk better than any other feature. And I want to review some very recent data in this regard. So here's a really nice, elegant demonstration of this principle that was published in JACC last year. This is taken from a large registry of CCTA in symptomatic patients from Denmark. And what they looked at was the cumulative incidence of events, major adverse cardiovascular events that is, first in the overall population stratified by obstructive versus non-obstructive coronary disease. And not surprisingly, as you can see on the top left, individuals with obstructive coronary disease had higher incidence of MACE than those with non-obstructive coronary disease. This is a finding that's well established. But if we look at this index to total plaque burden, here using CAC as the measure for total plaque burden, you can see that this relationship between obstruction and events goes away. So there's actually no difference whether an individual has obstructive coronary disease or non-obstructive coronary disease once we adjust for total plaque burden. And in the end, what we find is that patients with equal coronary artery calcium burden share similar cardiovascular disease independent of vessel obstruction. That is to say, plaque burden is what informs events, and plaque burden is the disease that we're interested in and what we want to prevent. Let's turn our attention now to another very recent high-profile trial. This is, of course, the ischemia trial, which was published in the New England Journal of Medicine last year. I think everybody viewing this webinar will be familiar with ischemia, which really tried to address one of the most important questions in clinical cardiology. That is to say, in individuals with stable coronary disease, is there an advantage to either an initial invasive or a conservative strategy? So this enrolled several thousand individuals who underwent stress testing as the initial strategy. If they had moderate to severe ischemia, they were eligible for the trial, and they were randomized either to invasive strategy, including coronary angiography and revascularization, or an initial conservative strategy, which was based on lifestyle changes in medical therapy. And as you can see here, the major results, both for the primary outcome, for primary composite outcome, as well as death from cardiovascular causes or MI, or death from any cause, there was really no difference in outcomes whether individuals were randomized to an invasive strategy or a conservative strategy. And this is now very consistent with what we saw for COURAGE. And I think we're seeing loud and clear that revascularization, at least as an initial strategy, does not have an advantage. I point this to your attention because there was a very interesting, very recent sub-analysis of ischemia that looked at the relationship of severity of coronary disease and ischemia severity on outcomes. So here, looking at the association between ischemia severity and outcomes, what they look at is mild, moderate, or severe ischemia as related to all-cause mortality, myocardial infarction, and the composite primary endpoint. And you can see that actually ischemia severity was not associated with increased risk after adjustment for coronary disease severity. Coronary disease severity essentially being atherosclerotic plaque burden. And you can see that whether we're talking about all-cause mortality or myocardial infarction, the degree of ischemia, the severity of ischemia was not related to either of these outcomes. On the other hand, when they looked at the association between coronary disease severity, i.e. 1 vessel, 2 vessel, or 3 vessel disease, or 50% stenosis greater than 70% stenosis, we do see that more severe coronary disease, more severe plaque burden was associated with increased risk, which is very consistent with the findings that we just looked at from the Denmark registry of CCTA patients, where plaque burden is what was most important in predicting events. So I think we have some very important clinical implications from here. First, among patients with stable coronary disease, CTA looks to be the superior approach relative to stress testing for risk prediction. And in fact, it's probably more efficient to start with CTA as the method of choice rather than ischemia testing for cardiovascular risk stratification. Unfortunately, it looks like we've been doing things backwards for the last couple of decades. We've really focused on the end stage sequelae of coronary disease. We've looked at stress tests to determine ischemia and invasive coronary angiography to determine stenosis. But again, as we've said, the disease is atherosclerosis, not either ischemia or stenosis, which are simply surrogates for burden of atherosclerosis. Plaque burden predicts risk better than any other feature. So using imaging that quantifies plaque burden is going to be most effective for detecting and stratifying risk. It's also important to recall that the majority of MIs occur in patients without either ischemia or stenosis. In PROMISE, we saw that more than half of the events occurred in those without ischemia. And in the Western Denmark registry, 2/3 of events occurred in individuals without stenosis. Now, you may come to the conclusion that, okay, I understand, plaque burden, it's where it's at, so we can use coronary artery calcium to quantify plaque burden. I think that coronary calcium is is extremely helpful, but what we've learned in recent years is that it doesn't tell the whole story. And I'll go into that in a little bit more detail. Here are results from the Scott-Hart trial. As you'll recall, Scott-Hart was a trial that looked at patients with chest pain and then randomized them to a CTA-based strategy versus standard of care incorporating exercise stress testing. And basically, they found that individuals who were randomized to the CTA group had a 40% relative risk reduction in the primary composite outcome. And that was mediated by the fact that individuals who underwent CTA received more preventive therapies such as statin and aspirin and lifestyle recommendations. Here's one sub-analysis from Scott-Hart, which indicates that actually incorporating information regarding low attenuation non-calcified plaque burden is also helpful. Of course, low attenuation non-calcified plaque is one form of non-calcified plaque that's associated with higher risk. We've known that this is a feature of plaque vulnerability and is associated with increased risk of ACS. Here, there was an attempt to actually stratify according to the burden of low attenuation non-calcified plaque. So looking at a threshold of percent atheroma volume of 4%, greater than 4% or less than equal to 4%, you can see individuals who had the higher burden of low attenuation non-calcified plaque had an almost 5-fold increased risk of fatal or non-fatal myocardial infarction. And in a fully adjusted model that included several measures of plaque burden, total plaque burden, non-calcified plaque burden, low attenuation plaque burden, or calcified plaque burden, in fact, the only independent predictor for fatal or non-fatal myocardial infarction was the low attenuation plaque burden. So it is important, and that obviously is something that you cannot get simply from a coronary artery calcium score. Now I'm going to take you to some very recent data. This was just published. This is ESCAPIST, the Swedish cardiopulmonary bioimage study, where they looked at the prevalence of subclinical coronary artery atherosclerosis in the general population. So this is a Swedish middle-aged population, a healthy group of 25,000 individuals. And they found that silent coronary athero is quite common. 42% of that healthy population has evidence of atherosclerotic plaque. This is very consistent with other population-based studies, which also show that the prevalence of atherosclerotic plaque ranges between 40 and 50%. Unfortunately, it's not uncommon to find significant stenosis even in this quote-unquote healthy population. 5% had a significant stenosis. And then when stratified by calcium score, some other interesting results for individuals with a calcium score greater than 400, about half actually had a significant stenosis. But perhaps even more interesting is if we look at the group with coronary calcium score of 0, a group that is discussed a lot, the so-called power of 0. Well, in this study, 6% of individuals with a coronary calcium score of 0 had atherosclerosis. A minority had a significant stenosis, but I think they did something very interesting. They stratified those individuals into the 10-year ASCVD risk group. So in particular, if you look at the individuals with a coronary calcium score of 0, who happen to have a 10-year risk in the intermediate range, that is 7.5% to 20% risk of MI or stroke within the next 10 years, despite having a coronary calcium score of 0, about 10% of these individuals were found to have atherosclerosis on the coronary CTA. So what can be inferred from these results? Well, of course, there's a high prevalence of athero in the general population without established cardiovascular disease. And unfortunately, even with a CAC of 0, atherosclerosis is not excluded, especially in individuals with higher baseline ASCVD risk. So I think this, plus the other data that I reviewed so far, really lays the foundation and a rationale for developing and designing successful risk assessment strategies that integrate coronary CTA. So if we were to review sort of the conceptual changes in coronary artery disease that have occurred over the last 40 years, we've really moved from the 1980s from a lesion-specific approach where the focus was detection of stenosis and treatment with revascularization to now a patient-centered approach, which hinges on detection of coronary atherosclerotic plaque so that we can not only detect disease early, but we can prevent its late-stage complications by implementing lifestyle changes and preventive medical therapies. Now, fortunately, there's been major changes in preventive cardiology. We're really in a renaissance for preventive cardiology, which is where I live. There's been concomitant increases and improvements in preventive therapies, so not only in LDL lowering therapies, but non-LDL lipid therapies addressing triglycerides and in the future lipoprotein(a). And of course, there's been many new therapies that have emerged outside of lipids. So in diabetes, thrombosis, inflammation, a lot of promising therapies. We also have new cholesterol guidelines as of 2018 and the first ever prevention guidelines. So there's really been a lot happening in preventive cardiology. And not only do we have new tools, we have completely new modalities. So we're way past just using small molecules for medications. We now have monoclonal antibodies. We have antisense oligonucleotides, soon to be approved as a small interfering RNA that antagonizes PCSK9, and many others that are in the pipeline. So there's a lot of excitement here. But I think we need to critically examine where we are. I think that the PCSK9 inhibitors, which are very potent LDL lowering drugs, have been transformational, particularly for those with an inherited hyperlipidemia and for patients who just can't tolerate statins and have atherosclerotic cardiovascular disease. But many have heralded the end of coronary disease with the advent of the PCSK9 inhibitors. And I'm here to tell you, sadly, that I don't see that this happening anytime soon. If we look at the results of the two large cardiovascular outcome trials, FOURIER on the left, Odyssey outcomes on the right, with the two monoclonal antibodies, we see that even in individuals who are getting their LDLs to about 30, we see that event rates at 3 to 4 years exceed 12%. So the area under the treatment curve in red is still quite high. So despite very low LDL attainment, there's still incredibly high rates of recurrent major adverse cardiovascular events. The change has been, though, that unlike a few years ago where we only knew about other residual risk pathways beyond cholesterol risk, we knew about other lipid pathways, triglycerides and LPLA, as well as orthogonal pathways, inflammatory, thrombotic, and diabetes risk. We knew about these, but we didn't have tools to do anything about it. Now, fortunately, today, we have new tools and evidence that tells us that if we target these additional pathways in patients where they are present, that actually we can improve cardiovascular outcomes. So we have many, many more options and much better evidence base. So it's really wonderful to have all these effective options, but the question now is, how are we going to match these drugs to patients in a meaningful and cost-effective manner? And this is where I think coronary CTA can really help, because it will allow a uniform approach to staging, classifying, and tracking atherosclerotic disease so that we can personalize therapy accordingly. So let me talk about some of these terms, staging, classifying, and tracking, as it pertains to quantification of coronary atherosclerosis. So here's one proposed way of staging coronary atherosclerosis. This is derived from 2 large CTA trials, Credence and Iconic. And you can see on the right some proposed absolute plaque volume ranges and proposed percent atheroma volume ranges. I think for ease of use as well as theoretical reasons that the percent atheroma volume staging system is probably the one to go with. And as you can see, if you have no atherosclerosis, then you're in stage 0. Stage 1 would be greater than 0% to 10% atheroma volume. Stage 2 would be greater than 10% to 20% PAV, and stage 3 greater than 20% PAV. And you can see the corresponding angiographic stenosis severity as well as coronary CTA absolute plaque volume ranges to the left. What about classification? We know that there's more to plaque than simply the amount of absolute plaque that's in the coronary arteries. And there's a full spectrum of plaque densities, so that on the left, you can have the very highly densely calcified plaque, the so-called 1K plaque, and on the right, the non-calcified plaque. And these are associated with different risk profiles and different risk for future events. And what we've learned in recent years is that, in fact, there's a continuum of risk of MI observed for plaques between compositions on the left, low density non-calcified plaque, and on the right, the 1K plaque. So on the far left, the low density non-calcified plaque and the napkin ring sign plaques, those are associated with much higher risk for future ACS. And on the right, the plaques with a dense calcification, so-called 1K plaque, are inversely associated with risk. So these things need to be taken into account. It's not only the plaque volume that matters. But I think where CTA offers a really unique opportunity is in disease tracking. That's simply not something that we can do with coronary artery calcium scoring, and certainly not practical with invasive approaches. And so I think CTA has principally emerged as a powerful approach to track the effects of pharmacological interventions on volumetric measures of plaque burden and plaque composition. And this has been shown for a variety of interventions, including statins, icosapent ethyl, PCSK9 inhibitors, colchicine, and even lifestyle changes, including diet and physical activity. And there's some common threads that emerge from all these studies. So all of these interventions essentially are associated with less plaque progression. There tends to be changes in plaque from the lower density to the higher density calcified plaques. And in some studies, we can actually see a reduction in low density non-calcified plaque. So all of these changes in plaque are associated with improved outcomes. And so this allows us to see if whatever therapies that we're starting in a given patient are actually working, or if we need to reiterate and become more aggressive. So along those lines, then we need to have a definition for progression and our ability to respond or understand how patients are responding to whatever therapies we're recommending. So here's just one proposed scheme, and this is based on some CTA trials as well as numerous IVIS trials. Rapid progression is defined as a greater than 1% PAV per year. On the opposite fold, regression is a decrease in total PAV. And then you see in the middle, you can have progression without stabilization or progression with stabilization. Progression without stabilization is a less than 1% increase in PAV, and most of the new plaque is non-calcified. On the other hand, progression with stabilization is also less than 1% increase in PAV, but most of the new plaque is calcified. So what evidence do we have that actually direct visualization of plaque helps patients to adhere to whatever recommendations we're making? And I think this old adage, a picture is worth 1,000 words, is quite appropriate here. We've known for quite some time, there's a rich literature that looks at the motivational effects of coronary calcium on adherence to a variety of medications, including aspirin and statins, and a variety of behavioral changes, including weight loss, smoking cessation, and others. Here's one such study that shows that as the coronary calcium score goes up, so too does adherence with statin therapy. And as the calcium score goes up, so does success with weight loss. And in fact, in a fully adjusted model, the best predictor of statin adherence and weight loss was the highest calcium score. And as I'd mentioned, there's been now many studies that have been done in this space. This is a large meta-analysis that looked at almost 20 studies that demonstrated that visualizing plaque does improve medication adherence and likely motivates patients to maintain beneficial lifestyle changes. So clearly, CTA has emerged as the leading tool to assess risk, stage, and classify disease, motivate patients, and track treatment response. However, in my mind, until these metrics are specifically linked to specific therapeutic recommendations, outcomes are not likely to materially change. And going forward, we'll need to develop algorithms for treatment based on risk factors and CTA disease burden and progression, i.e., just doing an imaging test isn't going to change outcomes. This needs to be linked to specific recommendations. Now, fortunately, this kind of work is going on now. The ACC innovation team clearly came together to form a working group to create such algorithms, which they call the treat disease algorithms. And I just want to give you a sense for what these look like. They look at the various cardiovascular risk factors, lipids, hypertension, diabetes, obesity, smoking, and they go through the various stages of coronary atherosclerosis based on percent atheroma volume. And you can see there's various recommendations for each of these stages. So to give you a high-level overview here, stage 0, no coronary atherosclerosis is seen on a baseline coronary CTA, so guideline-directed medical therapy given patients' traditional risk factors are provided. And in fact, shared decision-making for de-escalation of therapy can sometimes be considered in individuals who have no atherosclerosis. And then at some interval, the patient is rescanned. Here it's recommended at 4 years, and if no plaque is seen at the rescan, then of course they continue their current therapy. If there's disease progression, depending on how much atherosclerosis is found on the repeat scan, recommendations will vary. Here's stage 1 coronary atherosclerosis, so now plaque is present, and so there's specific recommendations about the use of statins and or ezetimibe. Patient is recommended to be rescanned in 3 years. If there's disease progression, then there's recommendations going beyond statins and ezetimibe, including bempedoic acid and PCSK9 inhibitors. And if triglycerides are elevated, then there's a specific recommendation about the use of icosapent ethyl. And then these patients are rescanned in 2 years. If their disease has stabilized at that point, you continue whatever therapy they're on. If there's progression, you go on to the next stage. Here's stage 2 coronary atherosclerosis. So now we're looking at individuals with a PAV of 10 to 20%. And there's even more comprehensive recommendations going beyond statins and ezetimibe to include antiplatelet, antithrombotic drugs like low-dose aspirin and rivaroxaban. Patients are then asked to be rescanned in 3 years. If there's disease stabilization, then of course you continue the current therapy. If there's progression, then you go on to intensifying lipid-lowering therapy, and you add an anti-inflammatory colchicine, which has been shown in randomized controlled trials to prove outcomes. And of course, if triglycerides are elevated, then also the addition of icosapent ethyl, and then these patients are rescanned again. And if their disease is stabilized at that point, therapy is continued. If there's disease progression, you proceed to finally stage 3 coronary atherosclerosis, which is the most comprehensive, as you can see in its recommendations. So there are algorithms for all of the traditional cardiovascular risk factors. I'm not going to go through all of these since we don't have time, but just to give you an idea, there's recommendations for diabetes and for hypertension, as well as behavioral modifications, including tobacco use and obesity. So to conclude, I really do believe that atherosclerosis is all that matters. And CTA really needs to be the front line, not only for detection, but for also coming up with our prevention plans. Diagnosis by CTA allows staging and classification. This can be automatically quantified with clearly algorithms, and plaque can be characterized. And then based on what is found, we can personalize treatment according to plaque burden and progression. Disease tracking allows us to potentially assess response and then react to what we find, so that if patients are progressing, if they haven't stabilized disease, we know that we need to do more. And I've showed you what those algorithms look like. But ultimately, we're going to need evidence that using plaque quantification tied to specific medical recommendations is going to improve outcomes. And I'm looking forward to the future when we'll have those results. But I really do think this is the way forward. So I'll thank you for your attention and be happy to take any questions.